My name is Chris Carrigan, and I'm the data advisor for Use My Data. I'm one of the three members of the Secretariat for Use My Data. We all work part-time. That's myself, Elizabeth, and Alison, who you'll have been contacted by at various points in time. These sessions are put on for Use My Data members to cover a range of things. Basically, the topics are anything that any of the members suggest we should put a subject on. And they're meant to be informal, quick, just 1 hour, as much time for Q&A and discussion as we can, but we'll go through one particular topic in some detail, and then people can chip in with whatever questions you want. All the topics suggested by you, so at any point in time, if any member's got a requirement for a student education session on any topic, you just have to email me or Elizabeth or Alison, and we'll put that on. We've got quite a few people this morning. We had about 30 registered. I expect we'll get about 20 coming in. I've had some apologies, so it's one of the more popular sessions. So ideally, if people can keep their microphones on mute while I go through some slides, and if you need to ask a question, either use the electronic hand, or at any point you can stick things in the chat, or if it's an absolute emergency, unmute yourself, because I know sometimes it's difficult, but with 30 people on the line, it's easy to try and keep it manageable for me. We're recording the session. It will go on the website so people can watch it afterwards. But part of the benefit of being a member is you can come and take part as we run these things live. So I shall get cracking as a member arrives. So this subject this morning was around basically what does my health record look like? And it came to us from several different people. So what I'm going to do this morning is to very rapidly go through a whole bunch of stuff around where your health data is and what it comprises, what it looks like, and show you some actual screenshots of real data at times, and then at other times explain what the data is, how it's put together, and cover off things like whether it's linked together, how a researcher gets access to it, what does a researcher see, just to try and give you a fairly basic level of what your data looks like in all these different contexts. So I'm going to stick some slides up now. No doubt. There we go. So hopefully you can see all those slides. So we're going to run for about an hour. I'll try and talk as quickly as I can and get through as quickly as I can so we can have more time for questions. It's probably easier if we go through the slides and then go back to questions afterwards. If you've got anything you do need to ask, feel free to stick it in the chat so it's not lost. That's all right, people. So this is the intention we're going to cover through this morning. The types of healthcare you've got, we cannot cover everything. There's a whole bunch of stuff that I won't be able to cover, but they'll give you a grounding. How it's created, what a way of this data generation thing is, how that maps to what you do when you walk through GP and hospital and various other places. Covering off things like who can see your data, but how much can you see? And how might you see it? And then the points about when a researcher wants access to your data, what do they see about your data? To try and give some very practical examples of what you see with your data, what a clinician sees, and what a researcher sees, and they're fundamentally different things. And if you've got any other things you want to add in, stick them in the chat and we'll pick them up towards the end if that's all right. So very quickly, your health data is generated, we put it at all points in life, but actually it's generated from before you were born, or will be generated before we're born for the newly arriving people on the planet. So health data is generated in, for instance, maternal health, pregnancy and birth settings. So as people go through pregnancy, that information is recorded as part of the healthcare, and when the baby is born, baby and the mother will have NHS numbers. Those two numbers are linked within the maternity systems. So as soon as you're born, your health data is begun to be recorded, begun to be generated. So it's right from the outset. Within healthcare setting, we all have an individual healthcare number. They're called different things across different parts of the UK, as you can see, but it's essentially one single NHS. I'll call it NHS number, just for ease. Other data is generated about you as you go through your early years life, whether it's in school-aged children, whether you've got various different tests and health assessments that are done. And as young people, you're going through various different health assessments and things during childhood and teenage years. So vaccinations would be one. Some of the stuff goes on your health record and some doesn't. So there's no natural immediate link from data which is generated about school activity and health into your individual health record. There can be at times, but there's no real clear close link. They tend to be quite separate systems, but it is health type data which can sit in all those different settings. More typically, for people as our age, because we've got no youngsters on here, no children on this call, a typical health journey. You would go in, you would make an appointment via your GP practice, and then you'd say I want an appointment for something. Now, when you go into GP practice, you'll have noticed that tapping behind the desk, that's on the GP practice IT system. So when you make an appointment, it's recorded on that system. You can give them a call, you can ask for an appointment, you can drop in, but all that information about you goes on that online GP practice system. You could also go through more and more online intermediaries, as I've called them. So rather than going into a GP-based system, there are other providers who essentially sell their services to GP practices and elsewhere that give you access to your record and to appointment booking, which I'll look at in a minute. But if you register with a practice, and we all will be, I suspect, then your details will already be on that GP practice system. And I put two pictures there, and largely those are being removed. So you'll very rarely see the old style paper notes, the Lloyd George envelopes in your GP practice. What you will see is people using GP IT systems. And that's one of the ones on the bottom, EMIS Web. So what's in your GP record? There's a bunch of stuff in there. There's a list of things in there which are examples of what is in your GP record. This is the information that sits on your individual GP system. Height and weight, through time, allergies, vaccinations, as I mentioned, various different examinations and medicines, things that are prescribed, an activity that takes place within your GP practices. Where you have a major illness which is being diagnosed outside of the practice in a hospital setting, typically, you'll find some information about that on there, but not a huge amount and often not available to you. But there's quite a lot on there. Many of us will have had access to our GP records. If you've not had access, there are a couple of guides about what you can find if you do want to go on there. This one is from the NHS in England. This was from the NHS in Wales, and other ones in Scotland as well. There's just a couple of examples. I will put these slides on the web with the recording because all these have got click-throughs, so you can click through to these reports if you need them, and you can click through to any of the examples I'll show as we go through. So you can very quickly find out what's on your GP record, and it's fairly standard across the UK. The ways of accessing it for us as individuals is different, and what you can see will be different. So here's one typical example of a GP system. This one's by a company called TPP, which happens to have got a large presence in the north of England, which is where I live. And this is my login to my GP record. So I can sit on my laptop, I can log into this system online system and log in. I can only log in if I've organized it previously with my GP practice, who can authenticate who I am. But once they've done it once, I can log in. It's a typical username and password. And when you do log in, you can see a whole bunch of stuff about you. So I blanked out some of my personal details, such as NHS number, for instance, and other bits. But you can see what's on there. You've got information about your appointments, past and future, medications, your overall record, vaccination information, and other things as well. So it's quite a lot. It's not everything. You won't see everything. But depending on the individual practice, they can open up more or less of that information to you. So it's a decision which the practice makes. So if you're part of your practice patient group, you could ask the question, what's our process for giving our patients access to their record, and how wide do we give that access? Or is it just a view of a small part of the record? And that does differ. It's worth mentioning at this point, this is at my GP practice system. Each GP practice has their own IT system, which is independent from any other GP practice IT system. They're often provided by the same provider. There's only really 3 main providers in the country, but they're individually held. They are not linked together. So my GP practice system in Manchester Road in Sheffield is not linked to the GP practice system, which is in Stannington across the other part of Sheffield, which is only 3 miles away. They're completely discrete systems, and the data is kept separate. And the individual data controller for those is the GP or the practice, the GP. So when decisions are made about who can access GP records, it's made by the practice. It's not made by a larger agency. And that can cause problems further down the line. You can also see your GP record in other ways. So for me, I'm a part of the TPP practice. I can download their app and I can see more or less the same as I can see on my laptop screen by logging in like that by using the app. And if you go to your GP practice, it'll tell you what system it's using and they'll give you a link to the app as well. So you can download the app for your own practice system and you can set yourself up and you can see all your different things on there. And it's basically a phone-based version of what you would have seen on the first screen I showed you, with a laptop version where you log in directly. And this is my record. usual thing, appointment, medication requests, and other things. This is all being driven, pulled from a GP system. Now, beyond that, we've now got national options. So across the different parts of the UK, you've got a national app and a health service app. This one's the NHS app, this one's the NHS Scotland app, this one's the NHS Wales app. And they each draw different types of information from your health record, and you can see more or less information on your health record on each of these three apps. I know what's on the NHS app because I've got it. I can largely see what's on my GP system and a few other things as well. So I can express my desire if I want to opt out of my data being used for planning and research, for instance. On the Welsh app, it's not the same as the NHS England app because there's a translation between England and Welsh, so you can have it in a dual language, and there's slightly different things on there. And similarly with the Scotland app, different things on there as well. But there are national apps where you can interact with the health service in some ways. You will see different levels of detail on the Scotland app than you would see on the England app, but that's just the way things are at the moment. So there are different ways you can see your record. So you've got access to it. So what does it look like? Well, your GP records information in a variety of ways when you pop in and see them, or where they get letters back from the hospital, and it all goes on their individual system. And what I did was I just went into the laptop version of my GP practice system and started to download and delve into what detail they gave me access to. So this is my actual health record that goes back a few years. It's not particularly spectacular, but what you do see is when you look at your GP record, there's a date against any level of activity, any level of interaction the GP has with you. There's a date. Decent. It also tells you who's been involved in that process of updating your record. In this case, it was a clerical person, and what they were doing with my record was to do with the COVID pandemic. So when COVID hit, there are various things and regulations which were passed, which meant GP data had to flow to national systems to manage the COVID pandemic. But when I look at my GP record, there's an indication that that's happened. So it's quite good and auditable. There are other things as well. This is done in 2019. And this was to do with requesting some pathology. So I went into my practice with a particular problem. They requested some tests which went to the hospital to get, and those test results came back and they're in my GP record, and I can see the summary of them, and I can even view the results of them in quite a lot of detail for each one of these things. You'll see there are different types of data in there. In this one, it's a full blood count with lots of different test results in there. The thing I point out is a few things. You'll see this very commonly across all health records in all different settings. Some data is structured, codified. So a date is relatively well easy to structure and you can understand it. There's a linking number with lots of different systems. So we talked about NHS number, but in this case, the sample ID number lets the GP practice or lets the IT systems link back to the actual laboratory system who got details of that sample ID, and they give it their own individual ID number, and that goes to in this case, on a GP record. So they can be linked together, and there's a whole set of words and numbers down here. Now, when this has hit the GP system, which is what I'm looking at, it's all come through as free text, unstructured data. When it's on the laboratory system, all these things are actually coded and structured, but when the data comes across, it's moved into free text to make it easier for the GP practices to read. Same example on here. This is a slightly different thing. This is to do with an X-ray, where the data within here is much more free text. So this was what the GP wrote in when they did the referral for me to get an X-ray. It's all free text stuff. It's not coded. And if you're way, way, way down the line trying to do some research into what happens with people with ankle difficulties, trying to understand all this free text is really tough. So there's a real mixture of stuff. There's also different ways that the results get recorded. So you'll see there, question mark OA left ankle, question mark stress fracture, and then above it, question mark OA lowercase left knee. So all sorts of different problems with recording things in free text. But this is in your record. You can see these things by and large now. Lots and lots of information. We mentioned referring from your GP to hospital. You go to your GP, they refer you to the hospital. That initiates some sort of electronic communication between the GP practice system and the hospital. It differs in different parts of the country, in different parts of the UK, but it's an electronic communication. So your record within the hospital system now begins to get updated as well. There's a sort of a link there between what the GP has sent and what the hospital has got, but there's no physical link between those two systems. They are completely disconnected. So that request sits on the GP system and the hospital system, and the hospital generates an appointment for you with the date, the time, and the clinic, and instructions to join. And that normally comes out in a letter, which also sits on the GP, on the hospital system, but often not on the GP system. I mentioned structured and unstructured. There's some more examples of structured data and unstructured data. Structured data would be a date, time, a code. The unstructured data would be the free text you've seen. And I mention that because unstructured data is far easier for us to read, but it's much more difficult for computers to understand when we come to how your data might be used for research. Unstructured data also brings in intrinsic risks because you can put whatever you want in there. So I could start in my GP record, I could start typing in details of somebody else, like Mrs. Bloke came in to see me and was talking about a husband who really doesn't get on with, and immediately that identifies the husband. So there are things within the free text area that people are cautious about because it could reveal the information about somebody else potentially. So you go into your hospital appointments, and the first thing they'll say when you pop into the reception desk is, what's your name, what's your address, what's your date of birth? And the number of times I've asked, people have come to me and said, why do they keep asking me these things? Well, it's because they need to check who you are fundamentally, but they need to check whether the details on their computer system are the same as the details on the GP system. Otherwise, you get lots of issues with disconnects and different sorts of information. You won't get asked, what's your NHS number, what's your CHI number, which is the NHS number in Scotland, because none of us remember those darn things. You do get asked your name. And because of that, those systems need to record your name. For instance, the receptionist can see it and they can talk to you and make sure it's you. So in that way, your name is seen by certain people in that setting. Similar to people say, why are you always collecting the same information? Well, by and large, they don't. Your information is checked rather than being recorded again. And that's part of good practice to improve data quality. So when you go into the reception desk, your details are checked and you're recorded as attending, and that receptionist can see who you are, but they can't see your full medical record. They couldn't see the things I've seen, for instance. And that's managed by a process called role profile, which is across the NHS, across IT, where you as an individual are given a particular role, in this case within healthcare, a receptionist. And to do your receptionist job, you need to be able to see certain things about me or you, but not everything. And that's how a restriction is immediately put in place about who can see what in your record. And role profiles apply across the board of healthcare, with nurses, with doctors, with researchers, and everybody else. So what about your hospital record? We'll have all seen the picture on the left. In fact, we're still seeing pictures on the left. We more and more are seeing pictures on the right being generated. Within hospitals, both these things exist. Within primary care, your GP practice papers largely gone. Within hospital settings, we still see loads of paper being generated. When it's the electronic version, the stuff that's in the IT system within the hospital, it's largely held in codes, but there's lots and lots of free text, lots and lots of paper as well. And they also got imaging data as well in there. So in the past, when you went for an X-ray, you may have remembered somebody having to get the X-ray developed, and they put it up on a big white screen, and somebody will look at things, the physical X-ray on a white screen. Mammograms used to be done that way all the time when I was setting up breast screening systems many years ago. All that's changed, and those images are now digitized, so they're much easier to see on an IT screen. They're much easier for AI and machine learning to begin to use, and we're seeing lots of development in that as well. But that's all data about you. The text is easier for people to read, as I've said. The codes are easier. Codes are easier for computers to analyze and for comparisons to take place. So it's a real mixed match how your record looks. And then the question is, well, what can you see of your hospital record? We've shown the NHS app, we've shown the GP practice giving you access to your record. What about the hospital settings? Well, by and large, hospitals don't provide you with direct viewing of your record for a bunch of reasons, some there. So it's very difficult for you to see your hospital record. There are some exceptions. So for instance, if you're one of the fortunate ones that sits in an area where a third-party provider provides this thing on behalf of the NHS, then you can see some of your hospital race record. But this is a subscription service the hospital needs to subscribe to. They need to commission, in this case, it's an organization called Patients Know Best, who provide software. The hospital commissions them to say, I want you to give access to the patients, and I'm going to give you the data to put on a system, and then this is your viewing platform for that. So this is a screenshot from the Patients Know Best website. There are other ones out there. And this clicks through. If you look at the slide afterwards, You can click on this, you can go on the website, see what it looks like. They've got some good case studies and examples on there. So some of us can see that, but by and large, the bulk of us don't have access to see our hospital records in the same way. So when you hear the sort of political rhetoric, if you like, oh, we're giving access to people to their records all the time, that's not true. We can by and large see our GP records, but hospital records pretty much not seeable by us. So for the majority of us, if you want to see your health records or your hospital, this is the way you do it. You put a subject access request in, provide proof of your identity, and you give it to the NHS Trust, fill the appropriate forms. And if you want to do this, it's a bit tortuous, but you can do it. You have a right to be able to do it, but it's not easy. And they've got 28 days to respond, which is not particularly convenient, but it is doable. But pretty much 1980s type technology, if you like. So there's a fundamental difference in how your health record looks and what you can see of it in primary care than there is in secondary care. If you did do a subject access request, because a couple of us have done those things, this is not my record, this is somebody else's, you, after a period of time, you get given a whole bunch of stuff, often on paper, but some on disk, on electronic media. And these are the sort of things that you see. So this is actually extracted directly from a hospital system about a particular person. This is real data with some of the stuff masked out. And it's been formatted separately by me. So I basically stuck this in a spreadsheet. But you can see pretty similar format. You've got lots and lots of codes. You've got lots and lots of values. You've got lots of things in here. So to understand this, you need to know what the codes mean for a start. And that's an extra step. And there's very little free text in here that's shown because quite often the free text is limited in what you can access because it could reference other people or other clinicians, for instance. But you can do it. This was the pathology text that we got back from one of the subject test requests, where you can see quite a lot of detail in there. And you can see the structure there, the specimen details, clinical details, microscopy, but a lot of it's free text. So this is direct from a lab system, which data which sits about you in the hospital. This is real data. Again, lots of text, but lots of codes in there that you need to figure out and decrypt. If you're on a trial, I'll mention trials quickly, because the data collection for those in a hospital setting is different. It doesn't link directly with hospital systems. It's kept separate for good reason. You don't want to introduce bias. You want to keep the data very clean. And you'll see on this is a trial participant sheet that I've had for a while now. They use participant number rather than NHS number. More and more trials are now including NHS number on there. But there's something there which identifies you as an individual as part of the trial, and they can ask a few different things. In this case, because trials are run very differently with the data is recorded, you're asked for your explicit informed consent, whereas when your health data is recorded, your consent is not asked. It's presumed that you're going to give, that you're okay with it because it's part of your healthcare. There are laws to protect that, to allow that to happen. But for clinical trials, it's fundamentally different. You're asked for informed consent, but everything gets recorded about you and what happens with your records. Consent's not the same in routine healthcare. And the other thing about trials is then they can record all sorts of other very, very specific data to the trial that you wouldn't see in your GP record or your hospital record had malaria in the last 28 days, for instance. Now, in theory, because malaria is recordable within GP and hospital settings, in theory, the trialist could say, well, I don't need to ask that. I'm going to look in the GP systems. I'm going to look for a condition of malaria being recorded, and I'll record it myself. But trials tend not to do that. They tend to record their own clean gold standard data. So again, you'll see data can be replicated in different places. And the last one of these, this is a further one down the line. So this is actually an extract from the cancer registration system. So the hospitals send data monthly to the cancer registry that people have been diagnosed with cancer and send their details on. So the same details will appear in this case, the Trent Cancer, which is a sort of Sheffield-based cancer registry system, which is a completely separate system from the hospital and completely separate system from NHS, from the GP practices. You'll see the information on there is the same because it comes directly from those systems, but it's held in separate areas. So that's data largely that's recorded about you as part of your healthcare. But what about other than your direct healthcare? So if you wanted to ask your GP, who else have you given my data to outside of the hospital for this treatment or for this referral? That's actually quite tricky. You can see some things in your GP record, So my GP record I showed the first line said my data's been sent to aid with the COVID pandemic, but quite a lot of the stuff where the data gets used may not be in there. It's quite difficult to find out. Um, it's even more difficult to find out data which sits in your hospital, how the hospital has used that for different things as well, because they do lots of things internally, but they also use the hospital data for research. That's quite tricky to find out. In fact, it's easier to find out in many cases where the nationally collated data sits. I mentioned the cancer registry is one, where all hospitals send data to the registry. Similarly, all hospitals send data to national data agencies for the health service, and that's in all parts of the UK. And you can see what happens with that data. It'll differ depending on which part of the UK you're in. Let's see a couple of examples. So don't get worried about what's in there, but this is a one-page extract of a large spreadsheet, which I downloaded from, in this case, NHS England, which is their data usage register. So all the data that's generated and collated by NHS England about you as an individual, and there's lots on there, can be used for other purposes, planning, for NHS planning, for research, and for other things. And NHS England, in this case, this is their data use registers to say where that data has been used. And this is just the page one of it, which says on the left-hand side, there's a reference number for the actual release for the piece of work. Then it says who's doing it. If you drill through into each one of these, you can say what that work is. You can say who put the application in. You can say what data they're asking for, what data sets they're asking for, what years they're asking for. You can see whether it includes identifiers or not. You can see what it's been used for, how it's going to be published, how it's going to be retained, and then how it's going to be destroyed. So that's a huge level of information for each one of these data requests. And you can look at those. If you choose to do so, you need a good few days to go through even one of these in detail. What you won't see is any ability for you to directly identify yourself. So if I look at any one of these, I could figure out, well, oh, if it's for national data and it's for everybody, or it's everybody being to pick their age, I'm probably in there in that data release. But you can't do that directly from here. So it's pretty much guesswork. But if you look at what these data are used for about us, this is our data. This is the NHS England one is since July 2019 when they actually were called NHS Digital. There's about 4,000 agreements which are on this spreadsheet. 95 out of the 4,000 are to with commercial organizations. 28 are IT health consultancies. And sorry, I put the acronym small medium enterprises, again, commercial type studies. About 4% of the agreements, 4% of those users are in those domains, commercial, out of 4,000. Within those 4,000 agreements, that includes over 65,000 releases of data. So files of data which can go out monthly, annually, or multiple sets of data files. And if you looked at one of those in particular, you could see exactly what those data releases were. You could see what the data files were. So there's a lot of data about us that goes out for people to use all the time. And it is quite difficult for us to track that. That was the England example. Wales have got their own data use register. They show their use in different ways. They've got a couple of graphs and then the detail, but it's the same stuff. So in this case, they've shown what areas of research your data has been put to and what sort of data sets people are most interested in. So I'm the top one there, patient episode database for Wales. That's hospital activity data. In England, it's called HES. So when you go into your appointments, you're on there. So your data, if you're in Wales, will be in that top line. Beneath this, they've got loads and loads of more pages of every single study they've released data to as well. But again, you'd have to guess whether your data's in there or not based on what you know about yourself. You can't identify yourself in there. And that's because it determines what a researcher can see about your data. So when the data goes to a researcher, what can they see? Well, the first thing that anybody would releasing data to a researcher or need anybody else has to do is this thing called data minimization. So here's a quick Ladybird book example of what I see data minimization is. I've mentioned two things before: my GP record, my hospital. I also went to the dentist earlier on last week. They've also got my NHS number and my details, and they link to NHS details as well. So within those three settings, that information about me is exactly the same. They've got all those things on their systems, ready to hand, things which directly identify me. When that data goes out to this, for instance, a secure data environment, which is what SDE stands for, this is a place where research can take place. My name wouldn't be on there. my NHS number probably would be, because this is still within the NHS, and it would let different things be linked together. But my name wouldn't be on there, for instance. And then if you go one level of detail further, if you go to a researcher, if a researcher was given access to the secure data environment or even given a file of data, they wouldn't have the NHS number. They wouldn't see the NHS number. What they would see is like a scrambled number, a made-up number, and they wouldn't see my name. They wouldn't see my full name. They probably wouldn't even see my full postcode. It's just down to SE1, which again is made up postcode, by the way. And they may not even say my full date of birth because they don't need it. So this is why how data gets minimized depending on who needs to see it for the jobs they need to do. And I'll come back to this point because it's an important takeaway message. Data isn't always the same as data. So when you see in the press, my data is being given to X, my data is being used for whatever, well, what do you mean by data? Because the data in my GB record on that line there is fundamentally different from the data a researcher sees. And when people talk in the media about data this and data that, it really annoys me because you've got to be very careful and think about what you mean by data. The other thing that's worth noting is that data doesn't sit like that. It doesn't appear as Carrigan Chris on a database. It appears as encrypted data. So that's actually the same records above which are encrypted. So even if I went into my hospital and stole their disk off their IT system, that's what I'd see. So that's another level of protection about how your data is protected and how your data looks to somebody who could just access the disk directly. Doesn't mean very much. I mentioned researchers. This is a proper bona fide, very large research program to do with colorectal cancer. And again, there's a click through from here if you want to click through it when you see the slides. But you'll see a couple of points there. They don't have the NHS number. They have a pseudonymized number, which is what I demonstrated back there. They don't have a date of birth. They have an age. They don't have dates of this and dates of that. They've got periods of time. So in this case, the days from diagnosis to death, which it eliminates the need for them to see dates, which could potentially identify somebody. So in this case, researchers seem very little, but it's enough for them to do their job. But this is data. But data is not the same as data. So that was half an hour. That's quick. So I think just to finish off now, and when I would open up some questions and discussions, and I'll check my chat. Your health data is generated in lots and lots of different places, more so than you'd expect. I mentioned the dentist there. The dentist generates health data, which goes in as part of your health record. The data standards and the coding systems are used to maintain consistency between different systems and between different hospitals. So all hospitals use the same coding mechanisms to make sure that when they mean something, it means the same to one hospital it does to another. GP systems or hospitals use slightly different coding and classification systems, but by and large, they're interoperable. You can convert between the two, but they do record things in very different ways. Fundamentally, when people see your records, they only see what they need to see to do their job. So the receptionist only sees certain information, and you saw that a researcher only sees very little information. That's very limited. Crucially for me, you can only see part of your health record, but you do have a legal right to see it all, or more at least. And that for me is a big gap. If we can't see our own health record, we can't see how it's been used, how is that going to affect trust? And my real key point around this is be really careful when you talk or see or read people talking about data, your data, because it means very different things depending on what's included with that data. Do very different things with it. Right. I'm going to pause now. And I'm going to stop sharing my screen if that's all right. So that was a really quick run through of what's in your health data, where it gets generated, and some indications of what's in it and what you can see about it. Were there any questions that people have got? Oh, I can see nothing in the chat, so I've clearly been talking too quick. Either stick in the chat or put your electronic hand up with any questions at all about this or anything that you've not seen. Who wants to start? Well, Francesco, you need to unmute yourself.
Yeah, thank you. Yeah, thanks a lot, Chris. You can't possibly cover every scenario of who may access data, who is the data processor and the controller. But what I would say is that in terms of clinical trials, where we've got the health research authority and the, I can never get it right, the Medicines Healthcare Regulatory Agency, they've got information or guidance about how to access electronic health records. So I guess there's different players, but again, that's different. I mean, I've got the app like what you've just shown, but my app to my GP, it doesn't even, in terms of condition, it doesn't inform me of all the conditions I have. But they use a system, like you say, called patches. But you know, it's supposed to make it easier to get a GP's appointment, but what the app does is that it tells you to do what you've always done: phone up at bloody 8 o'clock in the morning and stand in the queue and hope. So nothing's actually improved because they haven't got that technology added on to their particular GP access app.
That's interesting. And we're not going to turn this into a therapy session, but it's a good point you make, because your GP access is determined by your GP. And I know that I use the TP, or my GP uses a TPP system, as does a friend of mine in Leeds. I could do certain things and she couldn't with her records. So it's very patchy. And there are different ways that making appointments can be opened up. In fact, I tried it last week, just to try and make an appointment, and it's different for different people. Your point about a slightly different bit about who can get access to your record, I was trying to point out about how much we can see. But from a researcher, anybody with getting access to your record for other purposes, there are huge sets of rules and hurdles and forms and processes they need to go through. We did record a session on this, which I'm pretty sure is on our website, about a researcher's access to data, where a researcher came and talked about the things they had to do and the frustrations about the process and the mechanisms. So it's worth looking at that as a guide if you're interested in that as well. Jennifer.
Hi, Chris. Thank you. That was really good. You pointed out that there's not much of a link between the GP data and secondary care. What about within secondary care, kind of at both levels, like between departments within a hospital and across secondary care? Because with many people having sort of multiple morbidities, there often is issues when they go to a different department that they don't know what's been done or said by another consultant. And I just sort of wondered, you know, what the system is like in that respect.
Yeah, that's a whole different another session, but you're quite right. It varies across hospitals and across different parts of the country. So by and large, systems within a hospital generally talk to each other much better than they did, but they are quite different systems. But it isn't perfect. There is a digital maturity index, the NHS in England at least publishes, which shows you how digitally mature an individual NHS trust is, which is worth looking at. But it's not an easy read, and you've got to figure out what you mean by digital maturity. But by and large, smaller like lab systems within hospitals and things will talk to a main health record within the hospital. Many hospitals have combined their health records to change from an electronic patient record to an electronic health record, and that's now been pushed even further with integrated care systems, tasked with how on earth you try and coordinate all the activity across all the health related disciplines for an individual person. And to do that, the data needs to be available in one place for people to do that management. But it's patchy across the country. Some are better than others. The issue is wherever you sit in the country, you'll always have to span a boundary somewhere. So if you're in the southwest, drop into the southeast boundary. If the southwest have got their hospitals working collectively together with their data, it's all shared. As soon as you go for a referral down into the southeast somewhere, you're in a different world because those systems are not linked. So there will always be a technical boundary somewhere, wherever you sit, which means it's not perfect. But within a hospital, by and large, systems do talk much better together. The use of the NHS number is now standardized. Across hospitals within the trust network, it's much more improved. Between individual trusts, it's becoming better, but it's still marginalized. It depends on where you live. But there is a big push to do that. There's also a big push to bring together data on a sort of a federated basis, something in England called a federated data platform, which has just been commissioned, which hasn't started yet. And the idea is that the data could stay within the individual hospitals, but it could be federated for people to look at and shared in different ways. But the jury's out on that one, and we're waiting to do a session or a webinar at some point in the future when it's a bit clear about what that is. Madeline.
Hiya. So we've just come back from the breast cancer symposium in Birmingham, and we were chatting to one of the leads on the breast cancer audit. And one of the questions that we asked him was about the previous audit, the older people's audit, and whether or not we could maybe, use some of the information that was gathered from that. And he very much said, and it's just something that you've said now has reminded me of it. He said, well, we can't do that because we've destroyed it all. So obviously it's something that you just alluded to, that researchers have to destroy the data after it's used. Do you think that's a little bit too rigorous? And yeah, we were quite taken aback that the data's just all gone, all that work just gone.
So they don't have to destroy it. There are various different things that we put in place. So it's actually good practice to retain data afterwards, so people can go back and recheck the research that was done at some point in time. So there is lots of data from studies and trials and other things which still exist, will exist for many, many years. If somebody applies for data and said, I want to do this piece of work, and after that I'm going to destroy the data, and if that's the approval they're given, then they'll have to destroy the data. So in that case I'm not sure, but you could, well, I don't know, we could probably check, but there's a fair amount of digging need to be able to done that. As a rule, I actually think it's bad practice. And what I would prefer to see is where data has been brought together and a researcher or an audit process has produced something, I would far better see that data held in a secure environment so it could be rechecked and retested and revalidated and reused at a later date, because by that point it won't identify, well, it'd be very, very unusual if it identified a person directly, because it'd be sort of aggregated, summarized, de-identified data.
But I guess, like you said, if that's what they agreed to, then that's what they have to do.
You do what you say you're going to do, yeah. And if that is the case, and again, I'm not entirely sure what the application was originally with that.
No,
and I think that was for an audit rather than a research study, and there was a different application process as well.
Yeah, and I know that a lot of people are very sort of cautious about using data and scared of data. But when you see things in the media about the NHS is going to sell our data, I'm like, well, good luck with that. Do they know what they're buying?
Yeah, that's perfectly true, and it comes back, what's data? What do you mean by data? What level of data? There was a headline in the Times yesterday which was pointed out to me, where I think William Hague and might be David Cameron were quoted as saying NHS should sell its data to AI companies and make loads of money. That was my paraphrasing, but I tried to get into the article, but I haven't got. It's behind a paywall, so I couldn't see it. But there's a whole bunch of stuff you'll see in the media, which is just to grab headlines. I ought to mention we're trying to put together a webinar, or the concept of what a webinar might look like, around media stories about data and dig beneath the headlines. But we're just trying to figure out whether we can do that. That's for future reference.
That'd be interesting. Great talk. Thanks, Chris.
But yeah, you're right. The media stories tend to largely be negative rather than positive, and get positive media stories is really, really tough. That's probably where we have to come in. Julian, you put a question in the chat, raised an interesting question about NHS versus private dentistry. So private healthcare generally, private dentistry, private healthcare is a really interesting one. So if you're paying for something to get done, you're paying for a service, then that data is held in that contract with you. So it's quite different. There are some instances where if some healthcare or dentistry or other things is given within part of an NHS contract, that data does need to flow back to the NHS, to the national bodies normally. So your data would be included in that. So if the NHS is partially paid for your dentistry, that would be recorded in some NHS settings. If it's entirely private, then it wouldn't. That's just the same with private healthcare. If you want to be treated privately for a particular condition, that's up to you. And by and large, that data would not flow to the NHS. There are some caveats around that. So if it's an NHS lab that does the test and sends the results back to the body who sent the stuff in, sent the sample in, then that data might sit on an NHS system, and it might find its way then through to an NHS central system. But by and large, if you paid for something, then it's up to you. Julian.
Yes, following on from that, I've had an interesting experience this year with vaccinations, because I've received vaccinations as part of NHS programs. I've received them as a clinical trial volunteer, and I've received them by buying them at the pharmacy. So I've got a mix of all three in my overall vaccination record. And it feels to me that it's fundamental that from a public health point of view, vaccination data should be as comprehensively collected as possible, so that over time, researchers can go back and do checks like the check that was done on one of the pneumococcal vaccines to see, is there a link between timing of pneumococcal vaccination and various health outcomes that people are concerned about that are rarer in older adults. And there was a nice piece of work done quite recently, which was a whole country data set exploration, where they demonstrated that there was no difference if you looked at the 3 months before receipt of a pneumococcal vaccine and 3 months after, in the incidence of various things that people were concerned about. I think neurological incidents or something like that. And I volunteered to get my pneumococcal vaccination on a clinical trial. So effectively, I got either an experimental vaccine or the current standard randomized, and I still don't know which it is because the trial isn't finished. And getting that data transferred into my GP record has not been sort of simple and automatic. And I kind of hope that it might be simple and automatic, because I did give all the GP records details to my to the clinical trialists when I signed up for that. So anyway, that's just my 2 pennyworth and observation.
It's a really good point, and it's not simple. It's not automatic. That picture I showed earlier on of that, which one was it? It was Patients Know Best, which is a portal you can log into. Some of those systems do allow you to add your own bits in there as well. And I think some of the GP portal providers are letting you do the same thing, where you can add in your own bits. And more apps are being developed, particularly when people have got particular conditions where they can record lifestyle and activity and how they're feeling and other things. But they tend to largely feed research databases rather than feeding directly into your clinical record, because there's a real gap there. As I said, I didn't mention any of those. I also didn't mention any other apps like Strava or your Fitbit or your iPhone that tracks you as you go through your life, which could track health activity, how much exercise you're taking, how many flights of stairs you walk, how fast you walk, blood pressure, pulse rate. All those things are available as data about you. I didn't mention any of those because it's all out there, but it isn't routinely part of your health record. Some research studies do try and get access to that, where they would give you a Fitbit for 6 months and you'd wear it and various other things. But they're quite traditional ways of gathering data for that study or for that trial. And those data, as you quite rightly said, tend not to go back into your GP record, for instance. Similarly, if you're having vaccinations, for your vaccinations, one was given by your GP, the other one was done in Boots, for instance, and the other one was done as part of a trial. No. You can see the sense in pulling those things together, but at the moment they're not. The Boots one would be done privately, so that's up to them and up to you. It's technically possible, but they wouldn't routinely do that. And for the trial, you don't know what you were given anyway, and the whole point about the trial is nobody knows what you're given until the end results. So there's real problems about getting that data in real time. At some point, you could say, let's get this retrospective data together. Let's get it all in one place so people can analyze it after the event, which is what research is. And there is some work being done to try and do that, but it is a huge problem with the amount of data that gets generated about us as individuals. Any other questions people want to flag in my chats? What happens to Terence or Terry? I don't know which called Terry. I used to know a guy called Terry Kavanagh. What happens to data? What happens to data after somebody dies? I think we were going to do a session on this actually, because it isn't always straightforward. So in legal terms, the General Data Protection Regulation, so the Data Protection Act applies to living individuals. When you're dead, it doesn't apply. So different things can happen with your data. But by and large, when you die, your data is held for a period of time, and then it tends to be archived. So there are various things like National Archive where data can sit historically over time. There are some medical regulations which determine that medical records have to be kept for a specific period of time, and I couldn't tell you off the top of my head what they are, but there are some rules around how long data gets retained. Other rules about who can therefore get access to that data to do things like research. Death information, the fact of death stays around for a long time. Those never get deleted. But some of your medical records after a long period of time might actually get deleted. But I'd have to dig in some detail about what those individual things were. But there are rules. It's not just people don't just get rid of the data on a whim. They don't just give it away on a whim. It's still protected by medical confidentiality. The Data Protection Act is different, but you still got the duty of care, which still applies to you even after you die. So your data can't just be given away. Did that make sense? Did that answer the question?
Yeah, I was thinking of family, if it comes back to the family somewhere or other, a request to use that data, how it would affect the family.
So normally that wouldn't happen. There are ways when it can. So if you go to your GP with a particular condition, he or she thinks, "Ooh, it might be genetic," then there are mechanisms where you can do genetic tracing of family members. So there are processes that can be asked for where family members in and around you can be checked for their health records, can be checked for particular conditions, which could inform the care for you. It's called genetic testing, genetic counselling, really, more than anything else. And that does happen. It happens with the cancer registry process does that, looking for people within the same family who've also been diagnosed with cancer. But it's done under very, very tight conditions. But it can happen. But your data wouldn't be given as part of your estate when you die to your relatives, unless you want to keep a copy of your medical records, which lots more people do, and then it's up to you with what you do with those records.
Okay, thanks, Chris.
Any other points? Including, didn't understand a word of it. That was useless. Can we do it again? Jackie, I can see you got your hand up. I can see you on my screen. That was lucky.
Good morning. I was wondering, do we need to make a distinction between actually selling data, receiving money in return for here's the disk, and selling access to data?
Yeah. So we did a webinar, Does the NHS Sell My Data? Which again is worthwhile, where we cover this directly. So the NHS says it doesn't sell your data, but it can charge recovery costs to give people access to the data to do research, which sort of makes sense. But then within the webinar, when we went through how that works, we did a vote with the delegates afterwards and said, do you think the NHS sells your data? And they said, yeah, it does, but we sort of understand why. So the difference between selling and recouping your costs to provide access to data, for me, are much the same thing.
Okay, thank you. It's just that some people get very upset about
I think
it.
Down to transparency. If the NHS is letting somebody use data about us to do a particular purpose, it's nice to know what and why, what the safeguards are, and how we're all going to benefit, or is this going to help society or my children? So that's where transparency comes in, not just saying so and so's given this data. Well, why have they been given it? What's the purpose? What's the controls? What patients and public have they got involved in their work to make sure that they're doing the right things? And how are they going to disseminate the results and the findings they've got?
Yeah, thank you.
Madeline.
Do you think the NHS pays too much for these data platforms? Because my hospital, I'm lucky enough to be treated at a hospital that uses, am I allowed to say the company?
Yeah.
My chart. And apparently the cost of implementation of the system was huge. I don't know what it was. I don't have the number, but it was big. And do you think that maybe we could look at better ways to commission these things? Or do you think it's really important that my chart, for example, is completely bespoke to every trust?
It's really tough. And I can't comment on any individual one, but in general, there haven't been that many great to shout about IT procurements over the last number of years. There have been some within NHS Trust that have been very good, and some more localized systems which are really effective. If you look at national systems, there's not a great track record in procuring. Do I think individual organisations? So if I'm an IT company and I say, "Dear NHS Trust Chief Executive, I can make your data appear really good," and I go and show them a demo and it does look really good, then they might buy it. They might buy my service to do that. I could go to the next NHS Trust down the road and say, "Hey, I can make your data look really good, but I'm going to charge you to do it." And I could charge again and again and again and again, or do it slightly differently. And I have seen things in the past where things are done differently because NHS Trust want them done differently, which always bugs the hell out of me because I think that's a waste.
I kind of agree with you that I'm not sure that the NHS would get good value for money if it was buying for the whole of the NHS, just because they don't, as you say, they don't have a great track record, and the companies would see them coming. But I'm conflicted because I also think that my trust got charged too much for it.
Yeah, well, you can go and hammer them about it.
Although I'm glad to have it because it is, I am enjoying using it.
Yeah. There's a big push on integrated care systems in England and elsewhere, actually across the UK, where different organisations club together to try and do some coordinated procurement and delivery of technology for healthcare. But this is not easy. The NHS isn't one NHS; it's 10,000 different fish in a shoal of fish swimming through the sea, and at any point in time, 20% are swimming in exactly opposite direction to the 80%. So it's a funny old world. I'll just look at some of the chat as well. Treatment which is done privately. So any treatment which is done privately is up to you what you do with the data. Even if you requested a private clinic to send the data to the NHS, I suspect they would find it troublesome to do so. But what you can do, you can keep a record of your data if you want to. But the interface between private healthcare and NHS-driven healthcare is not great. Other points in there, implications in old age. Yeah, I mean, the other good thing about your health data, and we maybe need to finish on this one, is you've seen the complexity about what gets built up in there. I showed you one pathology test, and you can have hundreds done, and the volume of text in there, the volume of codes, the volume of information, the whole development of artificial intelligence isn't because artificial intelligence does one thing better, it just thinks faster. And because we've got so much data, the traditional way of an analyst looking through and charting and doing my spreadsheet I showed you for millions and millions and billions of records as they arrive, and they're arriving more and more, and you can't keep pace with them. Artificial intelligence and machine learning is a new technology within computing which can cope with that volume of stuff. And we've done separate sessions on artificial intelligence, but that's why artificial intelligence is becoming more and more and more popular, because the volume of data about us as individuals is growing hugely. The other reason it's becoming more popular is because we've seen things in the press and the media which come up to say the NHS data is worth £9.6 billion. And I could have showed you that headline. It was on an old slide. But people value the data in so many billions and billions of pounds. And Times yesterday with William Hague and David Cameron saying we can make billions by using NHS, by selling NHS data to the AI companies. There is financial truth in that. There's some merit in that. But what's behind the headlines? And how is that going to benefit me or society or us or our families or whatever else? So that's why artificial intelligence is really popular. That's why NHS data is really popular, because people are seeing there's power, there's influence, there's money, there's learning to be in there. And it's that learning and the development of new technologies, new techniques, new treatments that perhaps we need to focus on rather than people making huge amounts of money. I think we probably need to draw that to a close. We sort of got off tangent there a bit. I hope that was helpful. We've recorded this, we'll put it on the web as well, and you get a note in the newsletter to say where it's available. And I'll put the slides up this time as well for you, because there's some useful click-through links to all the ones I've sent. A final reminder that all these sessions are put on because people ask us to put them on. So any topic whatsoever, just email me or Alison or Elizabeth, and we'll endeavour to put them on, because all these requests come from you. I don't make these things up. I just have to pull them together. And hopefully, if you suggest them, then they are useful to you. Equally, if you find they're not useful, too long, too short, let me know as well. And more than happy to change and adapt to whatever you all want. At which point, I'll say thanks ever so much for coming along this morning. Good to see so many people here. I hope it was useful. Have a good rest of the day and have a good weekend as well. Hope it's not too wet and windy for you all.
You too, Chris. Thank you.
Thanks again. Take care, everybody.